Good morning to you all. Before starting, I would like to thank the organizers of this event for calling us. It's a big honor to us. I come on behalf of the Minister of Health, Dr. Gisela Amador. She appointed me because I'm the president of the Council, National. I'm a little bit nervous. The National Council of Palliatives. This is the governing agency, and we are made by the Social Security, which many of you know, it is one of the service providers at the Costa Rican level. Then we are made by private industry, private entities, and also some other agencies. And we would like to express how things been changed. We have started to work as a unit 18 months ago. Thanks to the collaboration of everyone, we were able to give out certain outputs. Now we have to discuss the law for those who are responsible of terminally ill patients, and also the law to guarantee the superior interest of children and adolescents. Next slide, please. Very well then. Okay, perfect. Thank you. I brought some pictures so that you can have an idea. Costa Rica is a beautiful country, relatively small, with a lot of complexities. We cannot compare, of course, with Brazil or Mexico, which have a lot of population. But I wanted you to have some idea of what these palliative care units mean. Fortunately, here we have two people who started working with palliative care who need to be acknowledged. Dr. Isaias Salas with adults and Dr. Quesada working with children. This is a unit at Dr. William Allen from Turrialba. They are not merely working at an office, they also go and work at home, at the households. Next slide, please. I want to clarify something here. The Ministry of Health is a ruling agency in Costa Rica to dictate programs, processes, plans, and policies in Costa Rica. We are open to collaborating with you if you needed anything, and we are open to your suggestions as well. Right now, we have a national plan on palliative care and a national council on palliative care, which I say it's the advisor to the ministry and to the minister, and this is why we're here. We have a legal framework which allows us to work from the political constitution. The social security scheme in its article 73 indicates that we need to provide the service to create assistance centers, provide drugs, and serve patients on a timely manner. These pictures were taken at the palliative care unit of Nicoya, which is a small city in the Nicoya Peninsula. And this is a notice that has been posted there so that all patients who arrived knew what were the requirements to enter a palliative care unit. One of them is to have a terminal disease, patients who have chronic diseases which restricts their life, or well-studied chronic pain. We are not making any differentiation if they are oncological or not. They need to comply with these criteria to enter. Belonging to the attraction area, well, this means that if I live here, I have a jurisdiction around me where people can have access to an center of palliative care here. From Nicaragua to Panama and from the Pacific to the Atlantic, we went through all the palliative care units in Costa Rica and we noticed all the different weaknesses and strengths. So we think we can offer a very clear situation of what we are living now. And the last thing is that there should be a treating physician. As a doctor, I can refer the patient to be assisted anywhere. This is our wonderful country. It's a small country, as I said, but as you know and as you can see, we have 64 palliative care units distributed all through the country. Some of them are national hospitals, some others are first-level clinics and second-level clinics. First and second level palliative care units. This is a metropolitan area where right now we see that we are too concentrated in palliative care units, while in the other areas, you can see here that in those parts where the metropolis is not concentrated, there are lots of units, while in Limon, which is the area of the Caribbean, which is very poor, as well as other areas, they don't have so many palliative care units. This diagnosis allows us to realize where we need to strengthen the material and human resources so that all Costa Ricans will have the same level of access to this kind of services. As I said a while ago, we have 64 units. What is a palliative care unit? A unit, theoretically, at least needs to have a physician and a nurse who are trained on palliative care. The Social Security, by way of the National Pain Center and the San Gabriel Hospice for Children, train the professionals who want to work on palliative care. They need to go through this training to be able to provide palliative care. It cannot be a general practitioner without going through training. This is what we require now. They need to accredit that they have the academic training or the university degrees which are necessary. When we talk about hospitals, it is not that the consultation happens they can happen at the hospital or in the household. 76% comply with the standard by the Ministry of Health. This has or contains the basics that you need to have for palliative care: human resources, infrastructure, personnel, documents. Those who do not comply with this standard, they need to improve what they have in order to be enabled to exercise this. They offer outpatient services. If they come to the clinic, they provide outpatient services. Now, at the Hospital Baltodano and Hospital Mexico, they don't have domicile visits. Two or three times a week, they can have home visits. We have different types of units: palliative care units, which are merely public. We have the independent units, and then we have mixed units. Those which are public belong with the social service. Those who have access to Social Security can have access with a terminally ill diagnosis. They can go to these services publicly. Fortunately, there are non-governmental organizations that are pushing to create mixed units. The mixed units have a big advantage. The Social Protection Board, which is the lottery, provides 22 million per year. Well, this is the basics, but they can have access to other projects through other laws. This is divided between the units or NGOs who are under the scope of this law and who are part of the protection board. They are mixed. They receive the resources from the lottery, and then they can hire staff. If the Social Security does not have psychologists, they can hire a psychologist, a nutritionist, and physical therapist or respiratory therapist to organize an integral group. And then we have the independent or private units. These are non-governmental units which found this need in an area where there's no care being provided, and they integrated as social actors themselves, and they receive funds or they compile funds with the community, with activities, and they hire specific staff for this. One thing I would like to mention, we went out there and we saw the units, and 100% of them were complying. This is a service of luxury. There's nothing to ask them extra of what they provide, because this is excellent. This is a Carlos Hospital, the palliative care unit. You see that they don't have much luxury here, but they have the basic stuff to provide a quality service. This is a part, this is the outpatient visit. They go to their households. They have 2 or 3 teams right now that are doing this. Costa Rica is a small country, as I mentioned before, but we managed to give everyone a little bit of what we do. We'll now have not communicable chronic problems. And we are being represented by non-governmental institutions. Dr. Quesada will take part in the National Cancer Council, and there's another palliative expert. And we have both visions at the same time. Instead of having this separated, we are trying to integrate. This is a palliative care unit of the Liberia health area. And as you see this card that you see here, the units might be obtained with the money from the lottery. The lottery provides the funds. And then we have the portable ultrasound machines. And these pictures were facilitated by them. And you can see what are the conditions of the patients, like the person in the center. The fan that they have there was provided by a non-governmental institution, an NGO, and they have niches. With the protection board, they have a right to niches on the wall, and they also have the right to receive training on basic RCP and palliative care courses at the national level. So you can achieve all of this if you have access to an external source of income. This is the palliative care unit at San Ramon. This is the house service that I explained a while ago. There's physical therapy, nutrition, and psychology. Everything is being paid by the organization because the social service back then didn't have the social security. Why am I mentioning all of this? You need a justification for a law, and this is a justification. They realize that if we have a law which favors people to stay within their homes, in this way we can reduce the stays at the hospital. I won't dwell here because my predecessors have already mentioned all the advantages that there is in having home care, so there's no sense in explaining this again. The evidence is the statistics from social services, and this is everything that we have mentioned already. As I said, all the doctors have to be trained on palliative care. We are now referring to the graduate level, postgraduate. We don't have undergraduate level so far. And this is for you to see the differences. This is the palliative care unit of Golfito, one of the last units that we visited. If you take a look at these, the resources are very limited, but we are managing to install these units with a certain level of quality. What is the law of benefit? As I said before, this is for patients who are terminally ill, and terminally ill are those patients who might have an advanced disease, which is progressive and incurable, which will entail the lack of reasonable possibilities to respond to a specific treatment, which life expectancy will be lower or equal to 6 months without prejudice of the fact that the patient might positively react to treatment, and this life expectancy could extend. This is very important. You see that it never mentions the word oncological, because some countries are only limited to cancer, but thank God we can do both, oncological and non-oncological. In case of people who are minors, which is fundamental, this is those who are suffering from a disease with significant effects on their health, which brings the patient at risk of dying, which treatment requires the participation of their parents or the tutors, the curators or the legal representatives, or if they are absent the closest relative in ICIN for their care. It depends on the time where the patient is declared as being terminally ill. I would like to mention here the great work that the palliative care unit of PDC León is doing. They have to use an aircraft to move from one place to another. They cannot take a car, so they have even sometimes to take a light aircraft. I will leave you with the presentation, but the only thing I would like to mention is that a person, everyone who's working, have the right to receiving this license. So this is an advantage because you as a parent or a partner or a family member need to look after someone, and you can stop working, and then you will receive this subsidy. Thank you.